discussing about to study the compare the result in early versus late traumatic cataract surgery and intraocular lens implantation.
Good morning everyone. I will be discussing study to compare the result in early versus late traumatic cataract surgery and IOL implantation. Introduction. Loss of vision due to ocular trauma is an important public health problem around the world. More than 500,000 people around the world are blind due to ocular injuries. Ocular trauma may lead to traumatic cataracts and thus contribute to notable visual morbidity. Traumatic cataract surgery can be performed either early in association with repair laceration in open globe injury at early days after presentation of penetrating injury, or as a late procedure in a quiet eye. If the lens capsule is ruptured and lens material has been introduced into the anterior chamber, it is preferable that the lensectomy can be performed as early procedure to prevent inflammation, lens particle introduced uveitis and glaucoma. Another advantage of performing the early surgery can be performed during same admission and reducing cost and time. The advantage of late procedure includes better IOL after suture removal. The literature available shows no consensus in timing of cataract surgery and its prognosis. Hence, it was decided to take up this study with the aim of comparing the advantages and disadvantages of early and late traumatic cataract surgery. Study was conducted in Department of Ophthalm, Muzaffarnagar Medical College. It is a prospective interventional study, and all patients with traumatic cataract who fulfilled the criteria were taken in the study. Patients were divided in two groups. First group, early cataract surgery in same sitting, and second group, late cataract surgery in the repeat sitting. The image shows the cataract surgery and repair of the laceration of the patients included in the first group, and the second picture shows the repair done in the first sitting, and cataract will be removed in the second sitting. Following surgery, topical antibiotics, corticosteroids and cycloplegics were prescribed, and further some examinations were conducted. The data was compiled using Microsoft Excel sheet using some standard tests. The results were that the age group less than 20 years who underwent early cataract surgery were 53.3% patients, and 60% underwent late cataract surgery. Further, the more affected gender was male. 66.7% underwent early cataract surgery and 60% underwent late cataract surgery. The type of soft trauma, blunt trauma, was in early cataract surgery 63.3% and 70% late cataract surgery. Mean axial length was 25.7 in early cataract surgery and 21.1 in late cataract surgery group. In early cataract surgery group, about 36.7% of patients in this study had vision between 618 to 624, and in late cataract surgery, about 46.7% of the patients had vision between 618 to 624. And during post-op, in both the cases, the vision was improved to 6.6 or 6.12. About 63.3% of the patients of early cataract surgery and 40% of the late cataract surgery had bag type of IOL. Inflammation was present in 10% of patients in early cataract surgery group, followed by raised IOP in 10%. In late cataract surgery group, raised IOP was present in 6.7% of the cases, followed by other complications. This study shows that about 30% of the patients with early cataract and 33.3% with late cataract were aged between 21 to 30 years, which was statistically significant. Another study also proves the same results. Other studies have also revealed that ocular trauma mainly involves children and young men. Hence, it is reasonable to perform the early cataract surgery to make visual rehab shorter and help in better anatomical and visual outcomes. On the other hand, late cataract surgery could permit to better IOL calculation, probably operating in an eye with less corneal edema, inflammation, and better evaluation of traumatic cataract. One study has also proved was done to determine the effect of interval between time of injury and time of intervention. In these patients with corneal restoration, traumatic cataract surgery was performed as a secondary procedure, and these group of patients had a significant higher post-op inflammation and lower final BCVA. They concluded it was better to perform traumatic cataract surgery as an early procedure because of lower complication rate. Other studies also proved that in the absence of fragmentized or intumescent traumatic cataract, to manage traumatic cataract, it is preferable to do secondary procedure. One study mentions that for better assessment of visual improvement after surgery, more accurate IOL complication and less post-op, it is preferable to do secondary procedure. Also, Agarwal et al. Have suggested that in the presence of severe corneal damage and edema, it is better to postpone lensectomy for better visualization during surgery. In the present study, we tried to make a model to find the proper time of cataract surgery. We did not, and we found that at 6 months post-op, the BCVA showed no difference among the patients in the two groups. PCR was not statistically different between the two groups. We found more zonulisis in the group 2. Finally, according to the study, there was no difference regarding visual outcomes between the two groups and no difference regarding intra or post-op complications. So early and late interventions could be considered equally according to the situation of each case and the treatment environment. However, we need more trials addressing mentioned limitations to say the correct timing of traumatic cataract surgery. Yes sir, सर जो यंग एज में उसमें सब ब्लंट ट्रॉमा सर वो थोड़ा